This podcast is not a replacement to any formal lectures or clinical placements.
Hello everyone, this is Anisha
and this is Kabita.
welcoming you to this case series episode 6. First of all, we are so thankful to you all for encouraging us by listening to our podcast. Your encouragement is what makes us energized to share our case discussion with you. In this episode, we have brought to you a case of 12-year-old girl with air discharge, a very common condition, right? So, stay with us till the end to know more about this case. Episode 6. A 12-year-old girl with air discharge.
A 12-year-old girl presents to ENT OPD with a history of profuse discharge from her right ear since 3 days. The discharge is continuous, odorless, and mucopurulent.
Profuse and mucopurulent air discharge. Okay. Has she complained of any pain or discomfort in the air?
No, there is no pain nor tenderness. She does not have fever either.
Well, if she is afebrile at the time of presentation, maybe it was there earlier. Any significant history of respiratory tract infections, maybe upper respiratory tract infection?
Yes, she had 2 episodes of upper respiratory tract infection last year. At both times, she had air discharge which relieved after using antibiotic air drops.
So, she had air discharge following respiratory infections in the past. And what about this time? Is there any triggering factor?
Yeah, she mentions about the accidental entry of water in ear while she was bathing. There was slight discomfort in the ear followed by profuse air discharge.
Okay. Is there anything significant left in the history or should we proceed to examination?
There is nothing much left except the negative history of headache and vertigo.
Well, persistent headache or vertigo would indicate complications and again she has painless air discharge. So are these all directing us to uncomplicated otitis media?
Maybe. Let's see. What are the otoscopic findings?
Sure. Tell me the condition of her tympanic membrane.
Well, on otoscopic examination, there is a large central perforation in the tympanic membrane. Edematous and congested middle ear mucosa can be viewed. Oscular chain is intact and there is a small polyp protruding out through the perforation.
Oh, and what about the degree of hearing? Is there any hearing loss?
Since the oscular chain is intact, tuning fork test and audiogram shows mild degree of conductive hearing loss in the right ear.
Mm-hmm. Okay, so summarizing this case up to this point, we have a 12-year-old girl presenting with non-offensive, profuse and mucopurulent air discharge for 3 days, and the examination revealing a central perforation in tympanic membrane and a mild conductive hearing loss.
And since the girl is repeatedly having the ear infection with permanent perforation in the tympanic membrane, we can move to the diagnosis of chronic suppurative otitis media.
Yes, you are right. I was thinking about this too. In addition to these features, the absence of pain, vertigo, and a persistent headache makes it an uncomplicated chronic suppurative otitis media, meaning the infection has not invaded inner ear or brain yet.
Great, we are done with the diagnosis. Now, let's discuss something about chronic suppurative otitis media in general.
Sure. Chronic suppurative otitis media is a long-standing infection of middle ear mucosa, characterized by air discharge and permanent perforation. It is of 2 types, tubotympanic and eticoantral. Tubotympanic is a safe and benign type, which involves anteroinferior part of middle ear cleft, that is, eustachian tube and mesotympanum. There is profuse, mucoid, non-offensive discharge with a central perforation of tympanic membrane and an absence of cholesteatoma. Intracranial complications are rare. Polyp, if present, is pale and there is mild to moderate conductive hearing loss.
Eticoantral is an unsafe and dangerous type in which posterior superior part of the cleft is involved. There is scanty, purulent fall spelling discharge, marginal perforation, often associated with bone eroding process like cholesteatoma. Polyp is red and fleshy. Complications are common in this type and there may be conductive or mixed stiffness.
CSOM is more common in the developing countries because of poor socioeconomic standards, poor nutrition, and lack of health education.
Yes, and it is the single most important cause of hearing impairment in rural population.
This disease may occur as a sequela of acute otitis media, leaving behind a large central perforation, or ascending infections via stage and tube in upper respiratory tract infection, or regurgitated milk or vomitus in infants reaching middle ear through stage and tube.
Likewise, it may also occur following accidental entry of water in the middle ear through perforated tympanic membrane, as seen in this 12-year-old girl, or using cotton buds or matchstick or other contaminated instrument for cleaning ear.
Now, let's move back to our case and discuss how we treat her.
Sure.
The aims of treatment in this CSOM case should be to control infection and eliminate ear discharge, and then to correct the hearing loss by surgical means.
Yeah, we need to do oral toileting at first, that is cleaning of the ear by drying mopping with absorbent cotton buds, suction clearance under microscope or irrigation with sterile normal saline. After this, we need to recommend antibiotic ear drops containing neomycin, polymyxin combined with steroid, which helps to dry up the ear temporarily.
Along with the drug, we need to advise for preventive measures in order to protect ear from future infections, like preventing water from entering ear by plugging the opening of external auditory canal with Vaseline smeared cotton wool while bathing, avoiding swimming, and not using contaminated cotton buds, hair clips, matchsticks for clearing earwax.
Similarly, the patient should not put oil or any other liquid in the ear that is not recommended by a doctor. Nose should not be blown forcefully, and in case of infants and young children, bottle feeding should not be preferred. Breastfeeding with child's head rest is encouraged.
Yes, these precautions should be remembered by all. Now, for this girl, we should proceed to myringoplasty for closure of the perforated tympanic membrane.
Absolutely. Myringoplasty is a surgical procedure which closes perforated tympanic membrane that helps to stop the ear discharge permanently and also to improve hearing and prevent complications.
The ear should be kept dry at least for 6 weeks prior to the operation, and there should be normal middle ear mucosa, intact ossicular chain, patent eustachian tube, and no infection in nose and nasopharynx before the operation.
Yes, this completes the treatment portion, and it reminds us that we are towards the end of this episode.
Oh yes, we had a great time discussing this case, and hopefully you too had a great time listening to us. Thank you all for your constant support.
Until next episode, goodbye everyone. Stay happy and healthy and keep learning.
Bye-bye.